Hi, everyone. Welcome to the ASTHO Deskside briefing on rural health. We'll just get started in about another minute or so. Joe, I think good to go whenever you're ready. Or Dr. Cantor.
All right. Good morning, everyone. I am Joe Cantor. I'm the CEO of the Association for State and Territorial Health Officials. It's very nice to be with you. We're very, very happy to bring this conversation on strategies to improve rural health across our states and territories. Let me hand it over to our Senior Vice President for Health Initiatives, Dr. Kimberlee Wyche-Ethridge.
Good morning and welcome, everybody. And what an honor it is to be here this morning for such this important topic. When we talk about rural health, to bring the experts we have to the table to bring you perspectives is something that we cannot minimize. It is my pleasure to announce the panelists that we have today with us. First, we have Dr. Daniel Edney, who is the State Health Officer for the Mississippi Department of Health and our ASTHO President-elect. Welcome, Dr. Edney. We have Robert Kruse, Dr. Kruse, who is our State Medical Director for the Iowa Department of Health and Human Services. And we have, I have to make sure I say your name right, Puthiery Va, who is our Director of the Maine Center of Disease Control and Prevention. All three will have the opportunity to give remarks, and then we'll go into a Q&A opportunity. If you have questions, you can put them in the chat throughout, and we will work on those after the presentations. So with that, it is my honor to pass the mic over to Dr. Edney.
Thank you, Dr. Ethridge, and it's such a pleasure to be with y'all today, especially on this Rural Health Day in Mississippi. What an appropriate topic. And we are so excited in Mississippi to have this incredibly important opportunity to invest in rural healthcare in Mississippi. Over half of Mississippians live in rural areas. And we know as we invest in making strategic, meaningful investments into rural healthcare in our state, we will improve rural health outcomes, which is really what is important for us. And as we improve the outcomes of our rural Mississippians, we'll be improving the health outcomes for our entire state. And to have this moonshot opportunity to really go after and attack some of the problems that have plagued us in our rural areas and in our very rural state are just incredibly exciting. These are problems such as the need for technological investment for our rural hospitals and providers, and to get them caught up, to have the real opportunity to make meaningful investment into the broad workforce needs that we have in our rural counties. And then very importantly, to really attack the difficulties that we have in Mississippi in our rural areas with transportation inadequacies. And to be able to do this in a way that will move the needle in the right direction for us in Mississippi. So we take this opportunity seriously. We are grateful and we are excited to get to work on this important project. And now I'd like to hand the baton over to my good friend, Dr. Robert Kruse, who is the State Medical Director for the Iowa Department of Health and Human Services. Rob?
Hey, thank you, Dr. Edney, and thank you again, Dr. Ethridge, and again, thank you to ASTHO for really bringing us together here I'd really like to share Iowa's perspective, which starts with a simple reality. Nearly half of our state, about 47.5%, lives in these rural census tracts, and one of the highest proportions in our nation. And that really means that any gap in access, workforce, transportation, or infrastructure affects a very large share of our families and communities. I'll say our rural health transformation program, which we call Healthy Hometowns, is one of the most comprehensive rural health plans that Iowa's put forward. It really focuses on three core goals. And first is to really ensure that Iowans can access the right care at the right time and the right place, ideally within their own communities. Second is to really improve those outcomes in areas where rural residents experience the greatest disparities, including chronic disease, maternal health, and cancer. And third, to modernize our data and technology infrastructure so that information flows seamlessly across providers rather than really expecting patients to navigate that burden themselves. When we look at the data, the need is really clear. Rural residents in Iowa drive about 30 minutes on average to reach a hospital, and that's double of urban residents. And our rural workforce is aging. About 27% of rural physicians are about 75 years or older, and these different dynamics are what threatens access and sustainability. So Healthy Hometowns responds to these challenges with 5 interconnected initiatives. The first is Hometown Connections. This expands our statewide kind of hub and spoke model, pairing rural hospitals and clinics with regional health hubs, again, to strengthen the specialty care and to reduce the need for patients to bypass their local system. And we also have Best and Brightest, which is a recruitment initiative that expands access to school-based care in rural districts. And the second is our cancer initiative, Combating Cancer, Prevent and Treat. And Iowa has one of the highest cancer incidence rates in the country, and our rural residents face lower screening rates and longer travel distance for treatment. And so we're building rural oncology networks that help bring those diagnostics, chemotherapy, and follow-up care closer to home. And we're investing heavily in prevention, especially whether it's radon mitigation to dermatoscopes and teleoncology in those trusted rural settings. The goal is to shift cancer care to earlier, more local, and more consistent for rural Iowans. Third, we're also launching our communities of care. These sites bring multiple services together: primary care, behavioral health, nutrition services, chronic disease management, and social support in one coordinated location. And each site includes a community health worker who will assist with navigation, chronic disease support, and again, helping dually eligible individuals access the full range of services that they would qualify for. Fourth is our investment in the Iowa Health Information Exchange, which nearly all Iowa hospitals contribute data to the HIE. And we're expanding our HIE connectivity across those rural clinics and public health, behavioral health, long-term care, pharmacies, EMS, to allow more providers access to comprehensive patient histories. And finally, EMS Community Care Mobile is another area of focus for us. We're modernizing our rural EMS with mobile integrated health teams that are capable of delivering home-based care, chronic disease follow-up, and stabilization services. The bottom line really is this: that Healthy Hometowns is designed to strengthen our rural care today and ensure it still exists tomorrow. It builds local capacity, it expands some of our prevention and specialty services, modernizes our technology, and supports our workforce, and invests more in the long-term sustainability of rural hospitals and clinics. So again, grateful for the opportunity to share Iowa's work, and we look forward to collaborating with states across the country as we all work to build healthier rural futures. So with that, I'm pleased to turn it over to Dr. Va, the director of the Maine Center for Disease Control and Prevention. Dr. Va.
Thank you so much, Dr. Kruse. And what I'm about to comment on, although Maine specific, I recognize that the folks on this call probably will hear recurring themes when you think about rural health and the challenges that rurality brings, but also the opportunities with this this new direction, this work. So how rural is Maine, for instance? So Maine has about 1.4 million people, but those folks are spread across a large land area, nearly equal to all of New England states combined. It is one of the most rural and oldest states in the United States. And when we think about our residents, similar to others here on the call, when they've noted, over 50% of our residents live in rural areas. 12 of our 16 counties are fully rural. And what does this mean? It means that this rurality really does shape every aspect of our healthcare system. Our communities face high rates of chronic disease. 1 in 8 Mainers have diabetes. 1 in 5 have lost teeth or lost 6 or more teeth due to decay or disease. And we know that oral health is part of all health. Our top causes of death still remains to be heart disease, cancer, and unintentional injuries. We know that the behavioral health needs here are very urgent. We have elevated rates of depression, suicide, and substance use related deaths. And so these disparities, we also recognize, also start young and start early in life. Maternal and infant health outcomes reflect a broader systems needs as well as systems challenges. So we do recognize that what's happening in Maine is similar to everywhere else, where there are indeed these complex health needs that are really compounded by an aging population, workforce shortages, and just logistical and financial strain in delivering care across rural settings like Maine. But with this, I also recognize there's a lot of opportunity and there's a lot of work that's already being done. Maine has a very strong culture of collaboration in communities. So when we are facing times of limited resources or ecosystem stress, we've seen communities come together across sectors and across geographies to reduce competition and build partnerships with the focus on caring for their communities. We are also intentionally taking action towards a more sustainable, population-centered ecosystem of care, one that really thinks about the clinical system, public health, and then everything in between, the space in between in terms of what population community health really looks like and how do you build those supports. So some of the examples of that is this. We expanded telehealth over the last several years. We've been actually doing this, expanded telehealth and access to telehealth. What this means is that we supported the capacity to deliver healthcare via telehealth, recognizing that distance and access is sometimes difficult. We strengthened our Medicaid and commercial payment policies to ensure reimbursement for those telehealth services. We've improved broadband because that's important in terms of supporting telehealth capabilities. We've also provided technical assistance to our providers and our healthcare systems in offering telehealth services. In addition to that, we are continue to support community health workers and paramedicine programs. We have expanded school-based health centers. We are engaging with mobile health units and mobile health programs to deliver care out in the communities. And then lastly, I do want to talk about even data systems and how connecting data systems is really important in terms of delivery of care. And why is that? It's because it ensures coordinated continuity of care among providers and provides better care for individuals and communities. It also empowers the patient to be informed of their own healthcare needs and how to advocate for their needs. And lastly, when we think about health information exchanges and how you create this integrated data system, public health is also a partner in that because we use that clinical information, population-centered information to really inform public health policies and strategies as well. So a connected data ecosystem helps providers, patients, as well as public health providers. But I will say this, is even with all this progress, we know there's a lot more work to be done. We know that there are challenges. So similar to what others have said already, and I'm echoing just as much, is that like other parts of the US, our rural communities in Maine continues to face healthcare provider shortages and hospital closures that have resulted in healthcare deserts. I recognize that there is indeed real financial stress related to hospital closures because you see less patients, it's a smaller size, there's greater vulnerability to economic fluctuation, so it makes it much more difficult to be resilient. We also recognize that rural hospital closures have a huge impact on access to maternity care here in Maine, creating maternity care deserts. So patients living in these communities have lower access to prenatal care services and experience higher rates of preterm births. Everything I've just said is, information that we've gathered through community listening sessions, definitely through this rural health transformation program process in terms of our application. But we have continued to hear this from communities over the last several years and continue to hear it from our communities even today. So essentially, I think here in rural Maine, many families, they face impossible choices between essentials like food, housing, and healthcare. And we recognize that these are not isolated struggles. Our public health hats through our public health lens and with our public health hat on, they really do reflect systemic challenges and barriers that undermines long-term health overall. So when we think about rural Maine and rural health, access and affordability, those aren't just barriers, they're really upstream drivers of health. Addressing them is essential to a population health approach that integrates clinical care and public health. We recognize the need to invest and continue to invest in prevention and improve these conditions that really keep people well, while also ensuring that the infrastructure is in place to respond when acute healthcare crises arise, because we recognize that that is not predictable either. So health systems really must meet people where they are before, during, and after illnesses. And I do appreciate this opportunity to talk about that so that we can continue to advance that vision. Thank you. And now I will be handing this off to back to Dr. Ethridge.
Thank you so much to all three of our speakers for their oversight and for really highlighting the urgency of the issues that we're seeing in rural health in rural America. I'm going to ask anyone who has questions to drop their questions in the chat, and we'll be able to start doing our Q&A session of the program. And while we're waiting for that, I have the opportunity to start the questions. So I'm just going to start with Dr. Va. You mentioned about working, she's like, oh no. You mentioned working with the community around some of the issues and some of the responses. And so my question was really about how has your state collaborated across state agencies and community partners in support of the rural health transformation program. And so you started that. Can you elaborate a little bit more on that? And then anyone else that would like to jump in about that collaboration around agencies and community partners?
Sure, I don't mind starting this conversation off. And I really appreciate that question, Dr. Ethridge. I really, when I talk about this as an opportunity, it was an opportunity for us here in Maine too, to open up that discussion. How do we work collaboratively in partnership? And how do you incentivize collaboration and partnership when we think about the ecosystem as a whole? And what we have done, again, with intention, is bringing all those voices together. We have our primary care clinics, like our federally qualified health clinics, among many other primary clinics as well. We also have care that's being delivered out in the community when you think about street medicine or mobile health cares or even school-based health centers. And then of course, what's also very critical is that acute care system when folks, for whatever reason, right, are facing an acute health crisis. And that's really important in bringing in our hospital systems as well. As a part of this process, we brought and convened all those stakeholders together and discuss where the conditions that we are existing in right now. So how do we incentivize partnership and collaboration, where you're thinking about the whole and not just sections of the whole? And what role does population health play in that? And I do believe that this is where, in creating a space for convening and recognizing roles and responsibilities and how you do that level of care and handoff together and creating those systems to support it. When I talk about the data ecosystems, I do think that's the first step, is to convening itself and recognizing we all play a role here and we need to work together. And the program, the Rural Health Transformation Program, sort of fast track that and put that on, emphasize that convening effort. And we're really hoping that we can now, because we know all of our partners, now we can actually emphasize and nourish those programs that already are starting and exist and allowing them to fully grow and bloom.
Wonderful. Thank you so much. Dr. Edney or Dr. Kruse, would you like to add into that?
Yeah, I can go ahead here. I'll say that, Iowa's application really reflected kind of a work of a broad coalition. Our rural health transformation team included leaders from Medicaid, from public health, from our compliance and administration divisions, the governor's office, some of our data strategists, our state office of rural health, obviously our communications team and our health economists, but external obviously work with EMS and government relations, all working together from the very beginning. We also engaged the Iowa Hospital Association, which conducted a statewide kind of hospital needs assessment, our Iowa Primary Care Association, and two of Iowa's largest health systems as well were at the table. And then obviously some of our universities and academic partners, through this as well. And this collaboration allowed us to assemble a plan that is, analytically strong, is very practically grounded, as well as thought to be implementable, hit the ground running there. So our plan called Healthy Iowans, or I should say Healthy Hometowns, is truly a multi-agency, multi-sector initiative, and really reflects kind of those strengths and expertise of those partners across the entire state.
Wonderful. Thank you.
Yeah, and in Mississippi, our governor's made it clear that he expects an all-government approach to implementation of the grant once the award is made, and so it was very much collaborative on the front end, led by the Office of the Governor, but also our Division of Medicaid leadership and Department of Health leadership, including our Center for Rural Health. All were providing the expertise as we were working out surveying stakeholders, having presentations from our stakeholders, and really just have as much of a conversation in the very short amount of time that we were all given to try to get as much buy-in and understanding. I'm sure that my colleagues are in a similar situation in Mississippi. We don't have one rural area. We have regions of the state that all are impacted by rural healthcare challenges, but are very different from one another. And so as we approach the challenges in our core Mississippi Delta counties, that will look very differently than our rural counties in South Mississippi or Northeast Mississippi. So making sure that we are listening to our stakeholders has been extremely important for us through the process.
Wonderful. Thank you all. We have a couple of questions coming in the chat. Thank you all. And also feel free to come off of mute and ask your question. You can raise your hand or so if you're not able to put your question in the chat. We have a question from Politico from Alice, who wanted to know about the policy and this incentives in the Rural Health Fund and how states will be scored based on adopting particular policies that the Trump administration favors. In particular, was it difficult to promise to change some of those policies without knowing what can pass through your state legislator? And I'll open that up to whoever wants to start. Dr. Edney, you got a smile, so I'm going to let you start.
The smile has to deal with the challenge that, again, a very short timeline, and that the deadlines certainly precede the reconvening of our state legislature in January. However, conversations had been going on through this time, and we had already been making state level policy changes administratively and in statute the last 2 to 3 years, which are scoring well in that, which should score well in the application. We had other policy decisions that were in the works that have kind of got expedited because of this opportunity. And then we've had conversations at the Capitol. We are a very strong CON state, and that does not score well, but our state has been looking at CON reform for the last 3 years, and very likely that will be involved in the conversation the next legislative session. There are lots of opportunities that will happen in the future, hopefully, but we have to the end of 2027 for legislative changes to occur in policy as we look at administrative policy changes that are currently ongoing.
Wonderful. Thank you.
And I can add, for Iowa, we've approached the application the same way. We've approached a lot of our federal opportunities, focusing again on the rural needs identified by Iowa communities, providers and hospitals, relying on some of the evidence-based strategies and ensuring alignment with existing state direction processes, including the legislative process, where appropriate. So around the question about promising changes without knowing, what can pass in the legislature, I think states were asked to describe areas of potential alignment, not to guarantee statutory changes, but our application stays within the current Iowa law and identifies opportunities to build on some of the existing work, such as the care coordination or digital health tools or data modernization and workforce initiatives, without assuming kind of future legislative outcomes. I would say regarding support or opposition to specific federal incentives, I think our role, as a state agency in health is to evaluate each policy area through the lens of what improves access, quality, and sustainability in rural Iowa. And many of these policy concepts mirror work that we're already doing or exploring. And while others would require, ongoing assessment and stakeholder input, it would be premature to characterize any kind of policy area support or oppose until that process occurs. But as for the timeline, as Dr. Edney said, the certainly ambitious, timeline there. Iowa kind of leveraged significant existing work in some of rural health needs assessments and workforce findings, as well as maternal health strategies. And because of that foundation, we're certainly able to respond quickly while still maintaining accuracy and transparency in a data-driven type of approach. So again, ultimately, our application reflects some of those priorities for Iowa and readiness, but not necessarily a commitment to adopt any one federal policy, but positions us to bring, again, some of those meaningful resources to those rural communities.
Wonderful. Thank you. Dr. Va, anything else to add to that? If not, I can move on to the next question.
No, I think Dr. Kruse and Dr. Edney covered it very well. And it's similar here, right? We're not building here. What we're doing is we're not building something from scratch. It really is building on pilots and evidence-based strategies that already work. And this is an opportunity to expand them. In addition to that, listening, I know we've talked about this, listening and alignment, listening to the communities, listening to the stakeholders in this ecosystem of care, but also listening to those that are involved in policymaking, including our government and our legislative branches as well, so that we're not, we're aligning those strategies accordingly, so that we're able to build versus starting from the very beginning. So all of this is very similar to our approach here in Maine too.
Wonderful.
And Dr. Ethridge, to that point, it's probably true for all of us, but one of the strengths that public health was able to bring to the table was needing to get a lot done in 2026. And we had been working on projects the last 3 years. We had shovel-ready projects that we were able to bring to the table to benefit the population health of Mississippi that we just didn't have funding, certainly did not have adequate funding to implement. So being able to look at those evidence-based policies that we knew was working in other areas, but have the opportunity to operationalize them fairly quickly was just a great opportunity that public health could bring to the table.
Wonderful. It sounds like a common theme across all three of your responses is that the work has always been happening. This is just a great opportunity to expand it in a way as you see fit for your particular state. So thank you. The next question, which we'll build on that, comes from Martha Bebinger from WBUR. And her question is, collaboration, you talked about the collaboration within your state. What about the collaboration across states, and what might be useful or even realistic? And let's see, I'll leave it if there's anyone that wants to start with that, or.
Well, Dr. Edge, this is the strength of ASTHO, is that the three of us know each other and have been working with each other, all along. And I respect my two colleagues and, what they're doing in their states and what their thoughts are. Certainly in Region 4 and Region 6, we're very close with each other. And we have been talking from the beginning, who's doing what in their states with the application, who has chief responsibility, what are you looking at, how are you looking at this, how are you doing it? And what's been really important, Dr. Va said, is we're all having the same challenges in rural health, and the need for rural health care is it's ubiquitous across the country. And, you know, independently, organically, great ideas are moving forward, and it's all very similar. There might be some variations on how it's, you know, operationalized, but you hear us all saying the same thing. All three of us are talking about the importance of technology investment and you know, statewide health information exchange that's meaningful and connecting all providers in rural areas of the country. I mean, just we all have transportation challenges, we all have workforce challenges, and what's interesting is seeing how those approaches are being attacked in Maine and Iowa, and likewise in Mississippi.
Wonderful, thank you. Dr. Vi, I see you smiling. Did you
Yeah,
have any?
no, it's so funny. Yeah, no, I completely concur with that. And, you know, asked it two things. Dr. Edney, you mentioned earlier in terms of like public health, like it's public health really is systems focused, and we don't, you know, we recognize that a lot of these challenges are indeed doesn't really also, you know, doesn't matter where the borders are. So similarly, you know, ASTHO has been doing this for a very long time. Public health as a whole has been doing this for a very long time, where we do actually work very collaboratively within our state borders, but also across the region as well. So similar to what Dr. Edney said, like, you know, here in Maine, we are very close and we communicate very regularly, whether it's with rural health or something else. With public health, we communicate very regularly with our other state partners, and we're always looking for opportunities to share ideas in terms of like how to respond and continue to meet that public health mission, right? We serve people, we serve our communities, and we, you know, definitely talk and share ideas in terms of like how to strategize, how to deal with barriers and challenges. But we also look at opportunities as well in terms of like how to work and coordinate together and communicate more effectively for people.
Wonderful, thank you.
Yeah, I'll just share. I mean, you know, I think it was both said by both my colleagues here. One of the most important parts of rural health transformation effort is that the rural health challenges don't follow those state borders, and patients cross, you know, county and state lines for care. Our workforce moves across regions, and the issues we're addressing, whether it's, you know, chronic disease or behavioral health needs, maternal health risks, data infrastructure, these are shared, you know, not just in the Midwest, but across the nation. And we're trying to achieve this together. So again, that's where ASTHO has been incredibly helpful. They've created that space where states can collaborate and compare approaches and understand really what's working in different rural environments.
The power of peers, of peer learning and peer sharing. Thank you. The next question comes from Kathleen Levingston from Route 55, and her question focuses on data. And she asked about if you could elaborate on any specific plans or strategies that your state may have when it comes to improving data tech infrastructure to improve rural health, particularly under the Rural Health Transformation Program.
Sure, I can go first on this one because you know, I think it's a priority for a lot of us state agencies. And thank you for the question. I think, you know, one of our priorities have been strengthening the health information exchange, specifically, you know, where we see kind of meaningful potential under this rural health transformation program. As we developed our application, we've looked closely about more consistent statewide kind of HIE infrastructure that could support rural hospitals, clinics, EMS providers, behavioral health providers, and certainly local public health providers. You know, we're you know, specifically some of the concepts that we've been evaluating around kind of reducing the burden on small rural facilities by creating more seamless ways to share information, whether that's discharge summaries or labs or imaging, care plans, primary care, EMS, and the larger public health ecosystem that wraps around that. Certainly also thinking about improving the continuity of care, enhancing our public health surveillance with more timely access to syndromic or maternal health data or immunization or chronic disease data, especially in those counties with limited analytics capacity, and then also supporting interoperability for behavioral health, you know, is a significant way to have that bidirectional data exchange. So for Iowa, the opportunity is not about kind of building a new system for the sake of technology. It's about creating a more practical, rural-driven pathways for that data to support better outcomes and reduce some of that administrative burden.
Mm-hmm.
I would like to add to that as well. Like same, I think I talked about this I think the beauty in like a system like health information exchange is that it's not just for the providers, but it's like there's multiple audiences here. And so it's really just reconnecting the dots and how you use that information. So for providers, in terms of continuity of care, I believe my colleagues can attest to this. As clinicians, it's very difficult sometimes to provide continuity of care because we recognize people receive care where they can, right? So you want to be able to have that information ready for you when you see the individual to provide the best care possible, and that you're not disrupting care. So for the providers is really important. So it doesn't really matter where people go for care. They'll be able to see the same story and follow along. In addition to that, for patients, they can take that information, learn more about their healthcare plans, and actually advocate for themselves. And I think the third pillar here that sometimes may not always be obvious is actually for public health, population health. I take that back, not public health, but maybe more population-centered approaches and strategies. We see that information as well, and we can use that to drive strategies that protect and promote well-being in the communities, as well as in the, for populations as a whole, in terms of like screening, access to screening, how care is being utilized. All of that can really inform policy and strategy for population health leaders as well.
Excellent. I love the three-legged stool analogy there. And Dr. Va, since I have you right now, there was a question that came through from Alice Olstein that said that Maine was very, very specific about rejecting incentives to adopt policies like SNAP, et cetera. Can you elaborate a little bit on those decisions?
I was hoping maybe, Alice, if you don't mind, can you elaborate a little bit on the question itself?
Yes, sorry, thank you. So in the state application, it says that states will be scored based on, where they stand on these various policies, and, whether they had already changed them or, plan to change them, or are looking into changing them. And Maine's application, was very blunt, I thought, about saying, we're not planning to do this. On the, SNAP restrictions, the short-term insurance market, scope of practice changes, lots of things that, some people favor, but some people find controversial.
No, I completely understand. And I think this is where maybe the best way to explain this is that, our states have, when we think about collaboration, and even in the public health space, what I've learned to appreciate at the same time is that the internal state dialogue and legislative and policy environment is different across. And the needs of states, but even in the states, like by county, the needs of our communities are very different. In terms of like, for instance, policies like SNAP restrictions, I know like here in Maine, this is a challenge and a struggle for a lot of our community members. Like they rely on these services that helps them out, helps their families out. Like I mentioned, we have a lot of older Mainers, but we also have a lot of young families too, that rely on these services. So when we think about the policies that we can't support, we really do have to put it into the context of our own legislative policy and legal environment. How feasible, how practical would it be to be able to support those ideas or policies, because sometimes it might not be as easy. So that's one. But also like the second thing, and probably more important, is the needs of your own community, because that's really important too. Like, is this something that we can support for our communities? Is this something our communities are telling us they need or they don't need? Because we do have to prioritize. In addition to scope of practice changes, probably very similarly, I feel like with a lot of the scope of practice discussions, it really is just navigating the internal environment to see whether or not this is feasible or practical, and then as well as need as well. So I do think like when we applied for this application, it had to be robust, but it also had to be targeted, and we had to think about practicality and feasibility and need. I hope that answers your question, Alice.
Yes, thank you. And if the officials from Iowa or Mississippi could speak to that as well, because in your applications, you went in the opposite direction and did say, we have either already made these changes or we're, really hoping to make them.
Well, Lord, in Mississippi, I've been advocating us having healthier food options in the SNAP program since the beginning of my tenure, as obesity drives the bus for us in Mississippi with our poor health outcomes. And March of Dimes just released the state report cards, and if you see the lion's share of preterm babies are preterm related to obesity and the mom. So having the presidential fitness test reinstituted to increase physical activity, to still give the same number of benefits, the same amount of benefits to a family, but directing them as we do in the WIC program to healthier food. It just, as a physician, as a clinician, it made perfect sense to me. I was very much supportive of it and was advising the governor to do it.
Yeah, and I would, agree with Dr. Edney's approach here. I think for us, Iowa's focus has been very clear. We built the application center on strengthening our rural access, supporting our healthcare workforce, improving care coordination without some of the predetermined policy outcomes. And I think this is just one of the spaces where we have aligned, as an approach here in the state of Iowa, and put that forth in our applications. So just consistent with our approach here, here in the state of Iowa.
Thank you. Our next question comes from Melanie Evans from Health Policy News organization, Trade-Offs. And the question has to do with the specific funds that are set, the parameters that are set for the funds for the rural transformation, and whether or not there may have been situations where the communities identified projects that fit state priorities, but fall outside of the scope of the rural health transformation. And if so, what projects fell outside and where do you go with those ideas? And I'm going to start with Dr. Edney.
There were, and there was confusion in the beginning because hospital leaders had been really told that this grant opportunity was going to backfill some of the Medicaid losses, and then that was not the case. So there's limited capital expense opportunity for investment in rural hospitals unless you're moving into a new transformative program or closing an access gap, which we're going to be doing a lot of in Mississippi. Direct payments to the providers were off the table. There had to be deliverables, attached. And so, but the way we're looking at it is the RHTG funding that we are able to get to rural healthcare is opening up opportunity of other dollars that can flow in a way that perhaps wouldn't be compliant with RHTG, but is very much needed in Mississippi. So it is freeing up state resources that we very much need to deploy into rural healthcare outside of RHTG.
Wonderful. Dr. Kruse, you look like you were coming off mute. Did you have?
Yeah, I would say, I think that's similar approach for us here at Iowa, as Dr. Edney had mentioned. There certainly was a lot of items that came out of our hospital association need assessment that may have not have been fit within the scope of the application. So I think that's, we want to listen to that and hear that information, because obviously that's our signal to our partners in that space, that those are our needs that they have. And even when they may not fall necessarily in the scope of work for the project, we need to be consistent thinking about how we can integrate those going forward. And I think this also kind of feeds back into, behind all of this here at the Iowa, and I'm sure other states as well, we want to think about the sustainability. Not just once 5 years is up, we need to be thinking about the levers that we can pull to think about how we can make sure that these are a sustainable approach to rural health outcomes and improving those. So I think taking that in consideration, those kind of needs that we heard from our healthcare providers and from our hospitals and other partners, is actually a helpful part of this exercise to think about how we could use that information to help kind of align that in other ways that may be outside of the scope of the transformation grant.
Mm-hmm. Wonderful.
I am just going to add to that too. Absolutely. Just because, like, again, I think this is one of those things where you're hearing similar themes. We heard the same thing from our healthcare partners as well, and healthcare ecosystem. And I keep going back to ecosystem because it really is that. I think with this transformation program, you know, there's an opportunity to think about population health and prevention. But of course, part of that spectrum of care also includes direct access to acute care. So we are hearing something very similar, and we recognize that you know, this program itself will not be able to address that, but we're going to have to figure out a way to do that because we have to support the ecosystem as a whole. In addition to that, you know, as Dr. Kruse mentioned, sustainability is going to be another challenge of ours, but we have to think about that right now because I do recognize this funding is a one-time funding. So whatever we have put in place, it really has to be able to sustain itself. And you know, we are thinking through what that could look like right now.
And that fits perfectly into the next question, which is coming from Carl Smith from Governing, and it has to do with our rural hospitals. And the question is whether or not there's been a conversation about working with stakeholders to work out payment models that give rural hospitals a chance to be profitable, not just exist. And with this infusion, for example, in some systems, insurers have agreed to actually fund a rural hospital budget. Is focusing on certain kinds of services are part of your initiatives? Dr. Edney, I see you shaking your head there. Mm-hmm.
Yeah, one of our challenges with our rural hospitals is, you know, we currently have a rural hospital system that was constructed in the 1950s and 1960s as a county-based system. As we've already said, those county lines are, you know, are really not very meaningful now when it comes to healthcare. And so right sizing healthcare and how that needs to look in rural Mississippi is extremely important. One thing we're doing is incentivizing independent rural hospitals to come together, to collaborate, to cooperate in ways that they never have, and stop looking at each other only as competitors, but, you know, as co-servants to their communities. And we're seeing already good models that have been happening outside of an equity model. You don't have to sell to a larger hospital to survive these days, but you do have to operate differently in the 21st century than you did in the 20th century. And, you know, and I think what everybody is very set upon is that at the end of this time of transformation, that we really have transformed things and not just propped things up for 5 years. So making investments in ways that make sense for rural hospitals. We're having hospitals in Mississippi change their designations, and rural emergency hospital status is making a lot of sense in our rural areas, incentivizing hospitals to, you know, to share their back office function and to reduce overhead together and to share providers. We'll never have enough providers in Mississippi Delta. So we have to share those providers to serve the communities in the Delta and do it in a way that improves their margins. And actually, you know, it's better for you to handle the orthopedics and we'll handle the labor and delivery and, you know, just all those things that we've never done before in Mississippi. And HRSA tells us if we can just reduce the number of unnecessary transfers from rural hospitals to a higher level of care and keep those patients closer to home by 10%, our rural hospitals move into the black. You know, they move to a positive margin. That's a really small number. And so this is very doable in our estimation. And we're excited to see groups of hospitals already coming forward and saying, hey, that makes sense. We can do that. We just need a little help to do it. And RHTG, that's, I think, one of the perfect examples of what it can do to revolutionize how healthcare is reimbursed. And then also for rural providers, remember, there are providers in rural areas that need help, not just hospitals. I mean, we have our rural clinics, our FQHC partners, our rural health clinics, our private clinics in rural areas need help as well. And so have opportunities to join ACOs without it being predatory, which it tends to be for solo or one or two provider rural clinics. They tend to be preyed upon, and to have opportunities within Medicaid in the private sector as well to give them alternative payment model opportunities like larger communities have. We're looking at all those things in Mississippi.
Wonderful. Thank you. Any other thoughts on that?
I think Dr. Edney had, kind of gave a great overview of that. I think, I kind of alluded to this in my previous answer about sustainability. I think in the back end, we need to be thinking about these conversations and as we're going through the evaluation process of some of this grant work, so again, continue to see what's working and what's not, and evaluating and seeing how we're going to ensure that sustainability. And I think we need to do that more through a statewide systems lens rather than asking each, rural individual hospital navigate this on their own. I think we need to know, that rural health works best when it's part of a coordinated system of care, not a collection of isolated facilities trying to sustain every service line independently. So from a systems perspective, we want to look at that regional capacity rather than individual facility capacity. Think about interoperable technology and shared data. What are the integrated workforce strategies that need to come together? And how do we really create a community centered design around sustainability going forward? And I think that's the only way, if we're not having those conversations, that we are going to continue to have a more system-wide approach to improving the outcomes here in rural Iowa.
Thank you. Dr. Va, I don't want to leave
No,
you
no,
out.
no,
I
it's-
have a thought on that.
No, absolutely. Dr. Kruse and Dr. Edney said it very well. We have to explore those things because sustainability will be one of our challenges, because it would be sad, right, to be able to transform something for 5 years and not be able to keep it up. And clearly, payment models are one of those tools, those strategies to be able to help us do that. So I know, like here in Maine, we are everything. We're exploring it all, and looking at it again to see, could we do something different to help sustain this process or sustain this system?
Wonderful. Thank you. I'm going to give the call out. Are there any other questions? You can put your question in the chat or come off of mute. Y'all have done such a wonderful job with your overview that you've just left everyone speechless. You've answered all of their questions. And if not, I would first of all like to thank each of you for joining in and sharing your expertise and your vision really for this once in a lifetime opportunity to really change, or as it says, transform the health of, as the statistics was given, 1 out of every 5 Americans, or in some states even more. ASTHO will continue to provide support to our members and our affiliates, and to bring people together like this in an opportunity to have that peer sharing and peer learning as a way that hopefully the changes that we're able to make will continue and be sustainable for a healthy future for all of our populations. And that is something that you just can't put a price tag on. So thank you all for the work that you do every day in public health, and the work that you will be doing as part of this rural health transformation. So much appreciated, not just from us at ASTHO, but for all of the people that you will be touching in the future. So thank you. Thank you. If you have questions after this, please, you can send additional questions or request to media@astho.org. Again, that's media@astho.org. Thank you all. Thank you everyone who joined us, and thank you for the thoughtful questions that you have added to this conversation. Much appreciated, and everyone have a wonderful afternoon.